to the chat, your organisation and what you want to get from today's Learn and Lunch. I'd just like to introduce myself as the chair of today's event. My name's Vicky Patel. I'm the chair of CAAW22, which is the National Quality Improvement Including Clinical Audit Network. I'm delighted to say that shortly we're going to hear from Sam Riley, the Director of Making Data Count at NHS England and Improvement. And that's regarding her drive and passion to support all of us to make data count. And in particular today, it's all about making clinical audit data count. We will also hear from our winning entry of Influencing Change Audit Hero about their experiences of effectively using clinical audit to influence change. So just to introduce the team to you today then, I've already introduced myself as chair. We'll be joined by Sam, who's our key speaker. We'll meet our Audit Hero winner. And then we've also got Layla with us. Layla Gregory is the chair of the London Quality Improvement Including Clinical. Got thrown out of the meeting twice. I'm so sorry about that.
I did as well. I think quite a few have, and Sarah has as well. Over to you.
Sorry, thank you. Shall I start again? I'll start on the agenda slide if that's okay with everybody. So I'm first of all going to talk to you a little bit about NQI-CAN and what Clinical Audit Awareness Week means for our audit community. We're then going to look at influencing change and what that means from a clinical audit perspective. Sam's going to talk to us about plotting that data over time and really making a real difference. We're going to hear from our winner of the Influencing Change Award. They're going to present their project, and then we're going to move to the opportunity for questions and networking before we close by 2 p.m, if that's okay. Right then, in the interest of time then, because we've lost a few minutes there. So Clinical Audit Awareness Week, it's run in conjunction with HQIP on behalf of our local clinical audit community. And we're all here every day doing what we're doing because it's all about high quality care for all. It's all about putting our patients and service users first, making that difference, helping our patients when they need us most, and providing that health and well-being to our local communities and all that are within that. Now, behind our purpose, we've obviously got multiple factors going on that do impact, and we must be aware of these and consider these in all that we do. Can you not see my slides?
No, they're not up at the moment, Vicky.
No.
Can you see them now?
Yes.
Vicky, can you hear me?
Oh, we can, Sarah.
Can I just please ask everyone present not to touch the controls on this lunch and learn, and please not to be disruptive. I've been removed from the meeting 3 times now. It's really important that we're able to celebrate this lunch and learn. So can I please ask people to be respectful and allow us to have our lunch and learn? Thank you so much, everyone.
Thanks, Sarah. So yes, so ultimately then we're aiming to provide that high quality care for all in the right place at the right time, whilst preventing harm and providing that best experience. So to get that right every minute of every day can sometimes be challenging, but we do continue to strive to achieve this. And we've got a duty to care. It doesn't matter what type of health and social care organisation that you're associated with. Ultimately, we're all here for that same purpose, and to ensure that we do get it right, and when we don't, we take time to reflect, learn and share together. So it's about us identifying where we need to improve. It's about measuring, implementing improvements, evaluating, particular emphasis on equity and access, and making sure that we sustain those improvements. And this week touches each day on these drivers behind our programmes of clinical audit for improvement. Now, this week provides us with an opportunity to share, network and celebrate what we achieve every day through clinical audit. And we want to share and learn together and on a much more wider scale. We want to understand the challenges to effectively getting the most from clinical audit as that quality improvement process. We want to take time to reflect, look at what's working and maybe where it's not quite right. Set ourselves some objectives to take away from this week back to our own organisations, teams and patient and service users. Let's shine a light on the impact clinical audit is making to improve patient care and services, and identify where our next destination is and how we're all going to get there together. So a little bit about NQICAN then. It's currently made up of 12 regional networks. Attendees at our quarterly network meetings consist of our 12 regional network chairs, 2 officers, which is myself as chair and Sarah as the general secretary. We have non-officers and we have co-opted members as well. Now, if you're not yet a member, please do get in contact and we'll direct you to your regional network chair. The chairs are all involved in Clinical Audit Awareness Week and you'll see them interacting with you all across each day of this week. And we're going to pop their contact details into the chat for you. The NNSF is a networking and sharing forum. And again, if you're not yet a registered member, head on over to the link and request to join. Becca's going to share the link in the chat and also the nqi.can1@nhs.net email as well. The NNSF is a fantastic platform. We discuss, we share and we learn together how we all use clinical audit for improvement. NQICAN's got a common purpose and a forward plan. The regional networks are actively involved in this and they provide a voice into NQICAN from all types of health and social care organisations, and they take that voice back out to the networks from bodies such as NHS England and Improvement, HQIP, NICE, Getting It Right First Time, Model Health System, Royal Colleges, other national clinical audit providers. And it's all about getting involved, making a difference and solving together. NQICAN's got annual priorities. They link into task and finish groups to complete on all of these. This information is cascaded through the regional network chairs to their members. If you want to know more, head over to the NNSF or get in contact with your regional network chair, or obviously email us in directly to the nqi.can1@nhs.net address. So we'd like to move you across to a Mentimeter now. So Becca's going to share a link in the chat for you. If you can click on that link, we're going to take you across. So we've only got one question on the Mentimeter. It's about utilising clinical audit to effectively influence change. What does that look like to you? So if you can all click on the link and head across. Becca's going to share the screen so that we can start to see your responses rolling as they go down. We've got 2 or 3 minutes here just to get posting. First things that are coming into your head. What does clinical audit to effectively influence change look like to you? Oh, lovely. So we're up on the screen. So hopefully you're starting to click into that link and we'll start to see your responses coming up. Lovely. Fantastic. Stakeholders is up there right at the start. That's brilliant. Gathering data. Yep, stakeholder buy-in, really, really important. Yeah, we've got that evidence base to test those changes on. Yeah, clear objectives. Yeah, we're sharing those results so that we're all learning together. Yeah, repeating cycles. Yeah, that visualization of data. We can't visualize it and share it enough, can we, to really be driving where we need to make those improvements and celebrating where we're doing well as well. Common purpose, communicating that need. This is good. Keep posting. Keep posting. Let's see your comments coming in. Improving data quality. Yeah, real issues. What are the issues and what's important to people? Brilliant. Senior clinical champions. Okay, we'll just give this another minute or so just to capture this, because this is really rich information. We are going to share the outputs of the Mentimeters from the week with you all as well. Yeah, embedding that learning and that re-audit. Yeah, communicate those results with appropriate people. Supporting that need for change. Love the smart actions. Yeah. Correct data to feedback any concerns in real time. It's about that timely review and action. Yeah, the buy-in, ensuring people know why we're doing it. Fantastic. This is all really, really good and it's all really, really valuable. Okay. I'm going to take back the screen sharing then, Becca, if that's okay. Keep posting if you want to, and then you can come back to me on the main screen as I talk, if that's okay. Just very, very conscious that we've obviously lost a few minutes earlier on. So I'm now going to talk to you about what influence and change means in terms of clinical audit before I hand over to Sam to talk to us. So, recognising that today our focus is how we can influence change, let's look first at defining influence and change. So change, this isn't new to any of you, it's an act or a process through which something becomes different. And when we talk about influence and change, we're talking about indirectly causing someone to change a behaviour, belief or opinion, or cause something to be changed. Now, when we look at effectively influencing change, we're starting to choose here how we can influence. This is about changing minds. It's about influencing, not manipulating. It's investing in. It's thinking about the way we approach this and using the clinical audit data and outcomes aligned with further information to drive the right changes at the right time in the right way. So in terms of clinical audits, it's really important to acknowledge that in order to influence change, we must first consider change right from the outset, through to evaluating the impact the changes have made to improving patient care and services, and is this change sustained? Any changes that we make need to be equitable and sustainable. They need to be important and matter to our patients and service users and our teams. What matters to you? What matters to me? We need to consider the impact of any changes on the whole system. So if we break that down a little bit further, any change to be effective needs to be well led. We mentioned on Monday about being inclusive, compassionate, kind and understanding. We talked about civility, a just culture, values and behaviours. Any change needs to be sustained, as in utilising available resources and make sure we're embedding, we're future proofing. And we're going to touch more on this on Friday when James Mountford joins us to talk about transformation. Any change needs to be equitable. We need to understand variation in terms of access, characteristics, ensuring equal access for all to high quality care. And we're going to look at this more closely tomorrow when Caroline Rogers from HQIT will talk to us about health inequalities. But when we choose how to influence, we can positively impact on others by investing in time, understanding and building that shared purpose and that collaboration. So what does that mean in reality then? So when we set off on our QI journey, we ultimately aim to bring about a measurable change. And if we've done really well, this change will be effective in making improvements and it will be sustained over time. However, how do we effectively influence change and what factors are involved? So we need to have that understanding and that appreciation of quality improvement and that ability to apply that in the real world. We need to have QI capability. We need to have the knowledge and the skills. We need to have that lived experience, and we need to be thinking about capacity and resource. We need that accurate information, data, patient stories, that evidence, that triangulation of information that provides us with that context. We need to understand that information and data, they're reviewed and in a timely way. The data, the information and the context by the right people at the right level in your organisation. And we need to explore embedding changes as routine everyday practice. And then, of course, we mustn't forget that we have to appreciate that leadership and culture absolutely critical in influencing how we affect change. And that is the behaviours, the values, that shared understanding, that compassion, that inclusion and collaboration, that psychologically safe environment that we talked about on Monday, making sure that everybody's got a voice, they're encouraged, they've always got permission to get involved, that just culture, not blaming people and making sure that we trust one another. It's that safe environment for us to be working at our best. And we must start to think more widely about systems thinking. Absolutely loads of resources out there on change in the public domain, behavioural change interventions, facilitation guides, tools and techniques. So plenty there for you to get your hands on. So what else do we need to consider then to effectively influence change? There's lots of models out there around influencing and change. This one's the change model from NHS England, a really good guide, a valuable book to work through. There's obviously the older models from Lewin and Cotter and everyone. There's the influence model here. This is taken from the CAAW22, the Quality Service Improvement and Redesign, really popular. We've also got to think about leadership, spread and change, and then obviously new challenges and opportunities as we move forward in this new world. So you can have as many models as you like to think about implementing change, but actually if you don't consider those underlying principles, which are your people, your systems, your processes, your resources, what matters to those that are involved, things won't change. Think about your human factors element and think about your resistance. But when we undertake clinical audit, we must apply those best practice principles to set things right at the start to effectively achieve improvements that are embedded and sustained and make that real difference. Effective change doesn't need to be big. So just thinking on a strategic level now then, change needs to align to your own organisation's improvement priorities. So what's your corporate strategy telling you? Your quality strategy, your quality objectives. Within your organisation, considering your clinical audit findings, does your strategy have a clear objective to drive change? Has that direct impact of clinical audit? Do you work in a clinical audit team or a QI team or combined? And if it's not combined, do you work collaboratively with your QI team if they are a separate department? Thinking about on a regulator level, thinking about CQC and when they've inspected and found outstanding organisations, when you look at what they find in terms of change and quality improvement, they talk about improvement methods and skills being available through research and innovation hubs, and actually having resources available within organisations. They speak to staff who tell them that they actually feel empowered to lead and deliver change, innovation celebrated, and there's clear and systematic and proactive approaches to seeking out and embedding new and sustainable models of care. They also usually find a strong record of sharing work locally, nationally and internationally. Staff feel empowered to suggest and deliver changes, and they're also encouraged to be innovative. And staff tell them that they feel strongly supported and invested in by leadership. They're proactively supported to acquire new skills and share best practice. And research and quality improvements were embedded in practice. And all staff were actively engaged in monitoring and improving the quality and outcomes for patients. So I think if we start to look at some of those organisations, there's things that we can learn there and start to review our own processes and systems we've got in our organisations. So how can we get the most then out of clinical audit to effectively influence change in terms of project design and methodology? So is your topic or even the focus appropriate? Is it an appropriate priority? Is it in an area that requires improvement? Thinking about clinical audit, who's leading on your project, who needs to steer your stakeholders to influence both results and change. You need the right people involved. How do you know who to involve and at what level and when? When we undertake a clinical audit and identify that non-compliance, what's the risk attached to that non-compliance? What actions do we need to take to reduce or eliminate that risk? Think back to Monday when we discussed patient safety. The risks here should be driving these changes. And then data triangulation, very much used in the world of clinical audit for ensuring consistency with data collectors or measures. But now when we talk about triangulation in clinical audit, we're talking about what else do we know? What other data have we got that provides us with that full picture? Then we can truly understand what's happening and if we need to take action to change, and also what that action might look like. Who or what roles are reviewing and understanding the data? Are they the right roles at the right level to influence change? And when you do identify that need for improvement, do you first look wider to align with your other improvement action plans in your organisation? Do you review the potential impact of any change wider in the organisation? And have you got that senior oversight or ownership of those actions? Clinical teams must be at the heart of learning. To be effective, learning needs to be shared in a way that's supportive and encourages that culture of learning. An effective dissemination of learning involves making the learning meaningful and powerful. So finally then, before I hand over to Sam, what can you take away from today if we set you a few challenges then? So within your organisation, we want you to consider if your clinical audit findings, are you aware of whether your strategy aligns with your corporate and quality strategies? Does your clinical audit programme include clinical audits that are in line with quality objectives or your improvement objectives for your organisation? Are your improvement actions taken forward with a focus on equity and sustainability? And do you triangulate your findings with other data And do you escalate those to the right roles, groups and committees to take ownership of any proposed improvement and actions that will strengthen your processes and your systems? It will address your inequities, your gaps, whether that's clinical and system-wide risks that we've highlighted through your clinical audit. And do your action plans align to other improvement action plans? So that might be within your organisation, or it might be wider within your ICS, regionally or even nationally. And do your findings from your re-audits or further continuous measurement confirm that actually your improvement actions have made a difference? So I'm going to hand over to Sam Riley now, the Director of Making Data Count, who's going to talk to us or talk with us about a focus on influencing change.
Thanks, Vicky. Hopefully you can hear me.
We can.
Good. I was also checked out the meeting twice. It feels more stable now, so fingers crossed. I'm going to go straight into showing my screen. Fingers crossed it's going to work. You can just let me know, Vicky, when a slide appears.
It's there, Sam, but it's not on screen share, it's your slide pack.
Okay, so hopefully it's now on.
It is. There you go. Yeah.
Fabulous. So great to be here. Great to see so many people. Wonderful. So Vicky gave me a brief before I ran this session, so I'm hoping that I'm going to keep Vicky happy in terms of having covered the brief. So let's see, we can test out with her at the end. And I am going to talk a little bit about SVC charts, but I'm sure that many of you have seen my training already, so I wanted to do something a little bit different today. So I had a chat with Vicky before we, when we were planning this session, and she said what she wanted me to focus on. And I started thinking about, well, what am I going to talk about? Because it is a little bit different. Obviously, plotting the dots is a key component here in terms of influencing change, but it felt like there was a lot more to that. So look, here's an image of me. Obviously, it's not me, thinking really hard. So what did I come up with? So I cast my mind back to when I did a job actually at NHS England a number of years ago, and I was Director of Insight. Now, I had various responsibilities as part of that job, and I was responsible for all of the annual surveys that were run in the NHS in England. And one of them was the National Adult Inpatient Survey. So it's something that's so a little bit of background in terms of the survey. So it started in 2002, and over the first 7 years, they gathered data from over 600,000 people. So that sounds quite good, doesn't it? So quite a lot of people having responded. I found this research paper, which I found quite interesting, and this reminded me of something that was very much in my mind when I did the job as Director of Insight. And this is an open access paper. I've got the link there at the bottom of the slide. So this was a piece of research that looked at how the data had been used in the inpatient survey. And I've just pulled out a couple of things here. So information alone does not automatically translate into improved experience of care. We can have loads of data, can't we? But unless we do something with it, is it actually going to make a difference? And at a national level, the results of the survey have been remarkably stable over time. So it's still running. It's been running for a long time. Now, I haven't done the job for a while, but the sense about 5 years ago was that there hadn't been any change in the data. Now, this is quite an expensive survey to run. I can't remember how much it costs, but it's a lot of money. Had it made any difference? Well, it might have done locally, but at a national level, we didn't see any change. Now, one of my other responsibilities was to implement something called the Friends and Family Test, which some of you will have heard of. I am hoping it's now not mandated, but for many years this was a mandated thing. We had to provide patients with the opportunity to provide us with feedback, and not everybody liked the Friends and Family Test. I'm not going to get deep into the Friends and Family Test now, but what was the key difference with the Friends and Family Test? Well, before I get into the differences between the survey and Friends and Family, this started in 2013, and just to put this in perspective compared to the survey, over the first 6 years, we gathered over 75 million pieces of feedback. So that's 1.3 million per month. So that's on quite a different scale, isn't it? And you know what? A couple of years after the Friends and Family Test was running, what did we see for the first time? We saw significant improvements in the NHS staff survey. Now, one of the things about the Friends and Family Test is it asked you if you were likely to recommend care to friends and family, but also every organisation had to provide the opportunity to provide free text comments. And the reality is, guess what? Most patients were really happy with their care, and most patients started writing really nice comments. So, you know, thanks to the sister on the ward, it was amazing. The care that I got was amazing. So, you know, is it terribly surprising? We didn't predict it, but there were improvements in the NHS staff survey because for the first time, for organisations that were reviewing the data and the free text comments, people were getting really good regular feedback. And it wasn't just about an occasional thank you letter or a box of chocolates. This was monthly data that was being fed back. And I can't stake my life on the fact that this is the question that improved, but having looked at the survey and trying to put my mind back to a few years ago, I'm pretty sure this is the question that we saw improvement in. So we can't absolutely prove that there was a direct relationship between the two, but I reckon there probably was. So we're getting all of this feedback and we're telling staff that they're doing a good job. So that feels like a good thing to have done. So let's look at a couple of key differences between the survey and the Friends and Family Test. So the inpatient survey, that's an annual collection. It's sent to a sample of patients. It's very, very lengthy. I remember my father had one years ago. It was probably about 14 pages that had to be filled in. And there's a large gap between the patient being discharged and the survey being sent and the results being published. So I'm going to come onto the timeline in a moment. What about the Friends and Family Test? Well, that was collected monthly. It was available to all patients in all settings. There were very few questions, and most organisations added in a couple of supplementary questions to gather additional data, but we're talking probably a maximum of 4 questions. Data could be reviewed in relative real time. And of course, the organisations that made improvements based on this data had processes to review the data on a regular basis at a very local level. So I suppose it just made me think, is there a parallel here with clinical audit? So I'm no audit expert at all, but you know, have we got audits that are very involved? There's lots and lots of questions. We go really deep. We probably don't do it very often because it's a really deep audit.
Sam, you're muted.
Very strange. Am I back?
You are, Sam. Yeah.
Very strange things happening in this meeting. So yes, so my conclusion is there a parallel with clinical audit where we do really in-depth audits? We don't do them that frequently because they're very in-depth. Could we move to maybe doing audits that are less deep but more frequent? And then we could focus on using the data. So that's just one of my thoughts, really. In terms of the timeline for the survey, okay, I was worried that I couldn't move a slide then, but it's all right, it's appeared. So this is what the timeline looks like. So the sample is taken in December 21, and that I think is taking a sample of inpatients that were discharged in the previous 3 months. So patients that were in hospital in the kind of late autumn. So what's the next element of the timeline? So in the February, patients are contacted with those lengthy questionnaires. Hopefully they do it virtually now, electronically rather than on paper. The data collection closes in May 2022. When do they publish the results? The results are published in May 2023. That's a really long time, isn't it? So is it a massive surprise? I'm sure this is a very useful piece of evidence for researchers, but is this helping change on the ground? Is it a surprise that those survey results haven't changed? I don't think it's terribly surprising. So is the inpatient survey, is that going to result in change like we see here on this chart? If you've attended my training, you'll have seen it before. We've got an SPC chart, we took a baseline, we made some interventions, and what we can see here is that the interventions absolutely worked. I think the friends and family test is probably more likely to lead to this kind of change. And of course, not all of our changes always work. So here we've got another SPC chart. This is looking at falls per 1,000 bed days. You can see they tried to do lots of things. There were lots of interventions, but did the interventions work? Well, they didn't, did they? Because we can't see any impact on the data. Actually, the variation in the data has got slightly more wide. So what do we do in this situation? Well, we don't want to ignore it. We've got some questions to ask. Were these the correct interventions that we tried out? Did we implement them properly? We might not have implemented them quite as properly as we've meant to. That's just life, isn't it? Sometimes we try really hard, but there are different factors. We don't do it quite as well as we wanted to do. And we might have done the right things in the right way, and there might be some other things that we need to consider, but we don't want to ignore our data if it looks like this. So we want to be evidencing improvement with data, and you're in really powerful positions, aren't you? You've got really important roles, all of you, to be able to do this and to start using your data in a brilliant way. So here we've got a nice example. This was a public paper. Again, I've got the link here in the paper. Why did this paper make me particularly happy? It made me happy because it had a beautiful SPC chart in it. Don't ask me about all of the clinical stuff on this because I haven't got a clue at all. But of course, I know about SPC charts, and I know that we've got a colour convention of orange is concerning and blue is improvement. So look, brilliant improvement towards the end of that graph. So what they did resulted in improvement. This same clinician, by the way, published another paper. He was brave. He published a paper where they thought they had improvement, but actually there was no evidence in the data. And we can learn as much from that, can't we, as when we actually see improvements. So Vicky's mentioned this already. So it is really important that we triangulate data. This is what I traditionally see people talking about when they talk about triangulation. They're probably talking about performance, finance, and workforce. But actually, is that enough? Does triangulation need to be a triangle? And I suggest to you that it absolutely doesn't need to be a triangle. I definitely want to see quality in my triangulation. And actually, if we think about the reality of real life, if we think about a specific example, if we wanted to understand what was going on in A&E, we're going to want to be measuring a whole lot of different things, aren't we? We're going to have some performance data, we're going to have experience data, some safety data, workforce. There's a whole range of things within here. So it's a lot of data to look at, but I reckon that there are different sets of people that would be looking at this in an organisation. So you wouldn't necessarily be looking at all of this yourself. Your workforce lead is going to be looking at the workforce stuff. Your quality lead is going to be looking at the quality stuff. And clinical audit is key to this, isn't it? So clinical audit is absolutely key to really understanding what is going on in our services. But I've got some thoughts in a few slides about how we can maybe make clinical audit even more impactful. There's a few things that we need to avoid that I just wanted to reference. So I found this little cartoon which I quite liked. So if we're collecting data, we really do want to be clear about the purpose. We just don't want to be collecting data for the sake of it. There's a cost, isn't there, to collecting data? So there's a cost from your perspective, there's a cost from a lot of clinicians as well. So we want to really be thinking about what we're going to be collecting and why and how we're going to be using it. So we don't want to be in a position where we're just collecting absolutely everything. And here's another little cartoon. It's a bit fuzzy, sorry about that. But you know, I think we're better if we keep things simple, if we collect a few things, the things that we know are important, and we don't morph it into something which just is more and more and more and more. I do a lot of work with boards. Boards look at integrated performance reports. Very often people say they want more measures put in the report. Hardly ever do they say they want them taken out. And then we end up in a position of not being able to see the wood for the trees, which isn't terribly helpful. How do we understand what's important? Well, I think there's no getting away from the fact that you actually need to talk to people. So I'm not a fan of meetings just for meeting's sake, but meetings can be really valuable, can't they? If we get the right people in the room, all of those people that have got an interest in a particular service, improving a particular service, we need to talk to each other, we need to use data, but we need to come up with what are the most important things here, and then we need to be focused on them. Oh, and we also need to avoid this. So let's imagine we've got the right measures, we've got lots of data. We might have a plan about what we're going to do, but we don't just want it to be just words, do we? We don't want to just have words that say, oh yeah, we're going to do this, this and this. We actually need to take action, because if we don't take action, then we're not going to result in any change in the data, and we're not going to see any changes in what we are delivering to our patients. Who's going to turn the data into action? Well, I'm sure there are lots of frontline teams that are going to be turning the data into action. But I would suggest to you that there's a whole set of directors in your organisation that should be taking an active interest in driving change. So all of these people should have an interest in driving different elements of change. So I'm hoping that you've got a bunch of directors that are really driving using the clinical audit data. And if you haven't, well, then you need to go and speak to them, I think, and make friends with them, is what I would say. It's not just about the directors. There's going to be a whole set of other people. Here we've got a young, very keen manager. She's very young, isn't she? Here we've got somebody in my triangulation session. I think this is the Assistant Director of Workforce. She is attending Making Data Count training when this photo is taken. That's why she's looking so pleased and happy. And then, of course, there are loads of clinicians, aren't there? But you need to think about who are your local people that are going to really make use of your data and make sure that action occurs, that those action plans are implemented. I suppose one of my last thoughts is, I know in the world of improvement, that's my background, there's kind of 1,000 flowers are let bloom. So people go away and they've got a nice little improvement project, and everybody's got a nice little improvement project about their little thing that they're particularly interested in. That's great, isn't it? It's great to have an interest, but I suppose I've got a little suggestion. That is that actually gaining the most for our taxpayers and our patients? So would we be better to be targeted? That's a little thought. Would we be better to all be focused on some key things? I don't know how you decide in your organisations what audits are going to be prioritised, but wouldn't it be great if they were targeted on the things where the performance was worse, where the performance was most variable? If we're failing particular targets that have a clinical implication like cancer targets, wouldn't we be better to focus on a few key things rather than have those million flowers that look very pretty blooming? And I reckon there are some key teams that are going to influence change. We've got the performance team, they know what's happening in terms of performance. Then, of course, we've got a risk team, they're going to be aware of different clinical risks. Quality team, they're going to have a lot of quality data, I'm hoping. And then, of course, we should have an improvement team in the trust, a QI team, and they've got lots of tools and techniques to help us actually implement change. Then, of course, we've got all of you, we've got the clinical audit teams. And I reckon that if we could put these together and focus on the right things and look at this fancy PowerPoint, isn't that nice? It only took me 2 minutes, honestly. It's all interrelated, isn't it? So we all need to work together. All of these cogs need to come together. And if we do that, then we're going to be able to focus on really using our influence to make things better for our patients. So last slide, some things just to think about. I always like to give people things to think about a little bit when they go away. And I wanted to reuse this fancy PowerPoint that I did for step 7. So this is a little signpost thing. So some things to think about linked to what I've said today. So how timely is your audit data? Are you collecting loads and loads and loads of stuff, but it takes ages before you feed it back to people? If that's the case, think about how you could change that. Is there a robust feedback loop? Are you confident that the data that's been collected is actually being used and an action plan being developed and implemented? Is the data really owned and understood? I don't know how it works with clinical audit. Is there somebody that really owns a particular audit? They own the data, they understand the data, they're going to make sure that something happens with the data. How's the data presented? Well, if you don't know about SPC, I reckon lots of you do, If you do, of course, you're going to present it when you've got enough dots in a making data count style. If you don't know about SPC, then there's loads of training. You just need to follow me on Twitter to find out what's available. Who is going to take action? Who's going to be the people that make sure that the action is taken? Have you got a director that you can make friends with to make sure that happens? How do we know if the actions have worked? Well, if you're doing shorter audits, you can do them more frequently maybe, and then we can have a look, can't we? Did our action result in improvements? And do the audits that you're undertaking support those priorities? I'm a big fan of let's do audits that really focus on where we've got challenges. And who are your champions? If you don't know who they are, go and find some, go and create some, go and make people really excited about clinical audits. So parting thought, as always, need to bring it back to patients. So if we get this right, we're going to be less headless chicken. I often say this in my training. We're going to be less running around and randomly doing things. And if we're not doing that, of course, we could focus on our patients because that's what we are here to do. So that's all from me, Vicky.
Thank you, Sam. That was fantastic. That was really, really good and really, really useful, and it's tying this in really, really nicely. So I'm just going to pop back to screen sharing now. Can you all see my slide? Can you see it? Yeah, lovely. So this is my holding slide for you now, Sam, to announce our winner.
And I can't see the slide, which is interesting.
Oh.
Can everybody else see the slide, or is it just me?
I can see the slide, Vicky.
Oh, okay. I can see it on my phone. That's quite interesting, isn't it?
Good. You're on your phone. Fantastic. I'm going to move the slide on if you're ready to speak then, Sam.
I am. So this is a very important role that I've got today. And people don't know the results yet, do they? So this is particularly exciting.
Hot off the press, Sam.
Hot off the press. So we want some Twitter action on this. I'll be tweeting later. So we have a highly commended. So congratulations to highly commended. So Deborah Douglas, enhanced recovery after surgery. And I don't know how to pronounce that last word.
Dr. Eaming. Dreaming.
That's a new one on me, but clearly some brilliant work undertaken there. I had a read of what you've done. So many, many congratulations. And well done to all of the team.
Fantastic. Are you ready for me to move on?
Oh.
Drum roll.
Drum roll. So the winner, very pleased to announce the winner of the Audit Hero Award for influencing change, overcoming the challenges of being an outlier, a multidisciplinary team approach to quality improvement for hip fracture patient care. So many congratulations. So Mr. Thomas Moores, and that's on behalf of the whole fracture negative female trauma team for Walsall. So wonderful work. Look, we can see lots of applause going up here. Well done. Now there's going to be a prize, isn't there, Vicky?
There's going to be a little token of appreciation and certificate posted out, there is, to the team.
So well done, and well done to everybody else that submitted. I'm sure you had loads of applications, didn't you, Vicky?
Absolutely, absolutely. Some really, really good project submissions. Yeah, so fantastic. Thank you, Sam. So I'm going to move the slides on then, if that's okay with everybody, and we're going to hear from Mr. Moores now.
Very exciting.
Hello, can you hear me?
We can. Fantastic.
Oh, fantastic. Okay. Well, thank you very much for giving us at Walsall Manor this amazing award. I'll briefly try and talk you through what we've done, but it's really quite a massive project that's gone on for the last sort of 3 years. But I will try and take us through all of this as quickly as I can. So my name's Thomas Moores. I'm the consultant orthopaedic surgeon and trauma lead for Walsall Manor. And then so you go to the next slide. The next slide will show you a fishtail, driver diagrams, run plots. So we did lots of that, but it'd be far too much to actually put into all of this. So I will skip through all of those and give you the abbreviated highlights. So next slide, please. So when you look at our at the National Hip Fracture Database, which is an audit of itself of all hip fracture care in the country. When I was appointed in 2018 to Walsall, we were not doing very well. Our mortality rate was 11.3, and that's 30-day mortality. So 11% of our neck of femur patients were dying within 30 days, which was an unacceptable statistic, really, especially when at the time the national average was 6.3%. So this meant we were failing our patients, and this was what gave us this massive impetus to change, or at least start thinking how we can improve things. Next slide, please. So yeah, we were on the naughty step, and we had to do something about it. And as you've heard throughout the whole of this afternoon, the way in which you do that is you look at what the challenge is. And so next slide, please. And the issue for us was where to start, because this was not a simple one solution problem. This was a massive, multifaceted, complex problem with lots of different things that we needed to understand. And we needed to look at the problem realistically in smaller chunks and start with small, easy win projects that we can actually have some meaningful change to hopefully over time have a larger overall effect. Next slide, please. As with the Avengers, we needed to assemble a team, and this team consisted of orthopedic surgeons, orthogeriatricians, anaesthetists, the trauma team themselves, the ward staff, physiotherapists, and a data clerk, and probably even more people that I've forgotten. But essentially, we got a massive group of people who had a vested interest in trying to make this work. We met weekly to look at in real time the data for our patients. And I suppose in hip fracture care, we're quite lucky that we have measures and data that we have to submit nationally. So we had many things that we were already collecting, but then we wanted to look into why we were not achieving various standards. And that's what we did each week to help direct which projects we needed to focus our attention on. And then we ranked those projects as to what we thought would be important. So for instance, one of the things is getting patients to the theatre within 36 hours. And patients that came in on warfarin, which is a blood thinner, meant that we couldn't operate on them within that time period because their warfarin wasn't reversed quickly enough. So we needed to address that so that we could actually optimize that patient and get them to theatre. Consistent orthogeriatric reviews was another hot topic, and also our physiotherapists were working incredibly hard, but we changed from a 5-day service to a 7-day service, but our physio department didn't have the same change at the same time. So it meant that on weekends, particularly, the physio targets were not being met. And this all meant a reduced standard of care. Next slide, please. So with all of this in mind, we found somewhere else in the country that had a very similar patient demographic to ourselves, and were doing it really well. So if they could do it well, what were they doing differently to us? And could we go and steal their ideas and processes in order to make our service improve? And I think this is really important. It's really important whenever you're doing anything is to look at yourselves and be honest and say, we're not doing this right, we're not doing this well. How can we improve? Is it we're doing things well, but we're missing 1 or 2 points? How can we change? And actually look into all these things. So going to a different place and seeing what they do well. And we took a team of us. So that whole trauma team and neck of femur team went. So surgeons, anaesthetists, physios, managers, ACPs, nurses. And we were very lucky that Rotherham was so accommodating, and they took us through all the aspects of the best practice tariff and how they managed to meet it. And therefore we could see how their care differed from ours, and it gave us 100 ideas. So now 100 more projects were in our minds about what we needed to do in order to improve care. Next slide, please. So for those of you who don't know, best practice tariff is something that was brought in by the government now back in 2010, and there are 6 standards, and initially there's now a 7th that you have to meet. And if you meet all of those, you get an uplift in your tariff by around £1,500 per patient in order to help develop your service and these things as a reward for the excellent care you've given your patients. So these were the things that we really wanted to look at, because what the data showed, if you hit these targets and your best practice tariff was good, your patient care was good, and therefore your mortality came down. And they were doing much better with their best practice tariff targets than we were, and consequently their mortality rate was a lot better than ours. So new slide, please. What we did was we met weekly, and every week we had a very great team that put together lots of PDSA cycles that we reviewed monthly to see which of these many projects that we were doing and identified which ones were doing well and which ones weren't, and then could we tweak them. So through that audit process of collecting all this data, reviewing that data, and then seeing what that simple changes that we'd made, did it have an impact on something else? And then we would re-audit and re-audit and re-audit in order to do this. But I think more importantly was all these projects were kept within our team. They were focused, and everyone had a role in order to gather those and report on those monthly. So we had that accountability and realistic targets. And these are just some of the many projects. So fasciitis block, 7-day physio to get patients with a bum off their beds on day 1, nutritional round, so we're getting the calorific, the calories that these patients need after a massive surgery into them so that their wounds heal better, they get less infections, dementia assessments. We were missing out on this, and it was very simple in order to improve that by just giving ownership to somebody. AKI pathway, that needed to be improved. Getting the patient's hemoglobin above 10 because they're more likely to walk on day 1. Constipation management, why? Because the opioids that they're getting constipate them, and that increases their delirium. And then also prioritisation of all this to make sure that these patients get to theatre on time. So we have a golden patient pathway now. All of these things all help in trying to meet those best practice tariff targets. New slide. So over the 18 months, we've definitely got better overall patient care. Our best practice tariff has gone up from 43% to 68%. Our mortality has reduced from 11% all the way down to 8%, and that's tracking the national average now. And certainly we're off the naughty list with all of the different agencies that we had to report to on a monthly basis. And that was just by, again, looking and doing full mortality reviews to see which things that we were not doing well at, and being honest and saying, actually, that patient's standard of care was good overall, but in this particular area, this wasn't great. How do we do better at that? A wound management chart, let's do that for all patients. Constipation and a stool chart, let's do that for all patients. Better fluid balance for all patients. And all of these things kept coming together to make our new NOF pathway booklet, which is easier for our juniors to fill in, so the documentation's better. It gives you hints and tips about all the different things that we should be recording, and also how to calculate things. So actually, if you follow all this pathway and this booklet now, it's very prescriptive of how we should be caring for these patients. Our fasciitis block rate, so this is currently a key performance indicator. We're up to 80% of our patients are getting it on admission. So that's with collaboration with our A&E team. So we do regular training every 2 to 3 months to make sure everybody in A&E can do these, to make sure that these patients are getting that initial pain relief, which then reduces their opioid need, which reduces their constipation risk, which reduces their delirium, and consequently we can get patients to theatre quicker because they don't have that early delirium. And most importantly, these patients are now comfortable, and we can repeat that fasciitis block, but hopefully we can use that once, get them to theatre very quickly, and it improves everything overall. Likewise, all this, like I was saying, reduced our time to theatre down to 44 hours, which is outside the best practice tariff, to 33 hours, which is under that 36-hour window. So all of these things, we know if we operate on them patients early, their mortality reduces and their outcomes are better. Also, the knock-on effect of doing all of these things is our length of stay reduced. So it was 21 days and it's now down to 14 days. So we're getting patients in their surgery, rehabbed and out of hospital. And that's with massively hard work with our discharge planning team, our physios, our OTs, so everybody, everyone on the ward, but all of these people working really hard together and having these standardized pathways. We're getting our patients out quicker, which actually, again, is better for our hospital. It means we need less beds for trauma, but also it's better for these patients, certainly in COVID times, reduces their risk of getting secondary infections such as COVID. And over time, our mortality has decreased, and actually we're now, like I say, tracking the national average, which is all we could really ask for. So within 18 months, we were no longer an outlier. Next slide, please. So, I'm sure you're all very familiar with this. What did we do? So we had specific projects, we had measurable things, and everything done achievable, accountable, and realistic. And every time we could see that, and the team around me were much better at doing all the run plots. Our QI team supported us massively with all of this. We could actually see that we had sustained change over time, and this is now the new challenge, is making sure that all of the things that we've been doing really well at, we don't fall back on. So it's now keeping on top of each other, keep on talking. And actually recently we've just had a massive neck of FEMA event in our hospital where we invited a neighbouring trust to come and share experiences, to actually reinvigorate our team, to look at all these things and actually keep on working hard together to make sure that we're all accountable and we keep on offering the best standards of care. And I think that is the most important thing. Build your team, communicate well regularly, and actually all the small little projects that you do really, really do add up to big changes. Next slide, please. So the future, we've been very lucky. We've managed to put business plans together, increase our ACPs. We're looking into cell salvage, enhanced recovery. So we've got lots more new projects coming along. But the reality is, it's all about that team working well together and holding each other accountable at all stages of this. And if we are falling off the pace with one thing, how do we change that? How do we do this? Is it training? Is it new support? Is it because we've got staffing issues? And actually being really honest about what the problems are and realizing what we can achieve within the system that we're in. I'm not going to say any more. I think I've probably taken up enough time. I'd just like to thank you all again for acknowledging our work. Walsall is a fantastic place to work, and it's been a pleasure for me to be a part of this team. And I hope that we carry on doing amazing work together and improving the standard of care for all of our patients in Walsall. So thank you all very much.
Thank you so much, Mr. Moores. That was absolutely fantastic. It was.
So just ask any questions, which is the next slide.
Yeah, you can see why you won all the way through. It was so innovative, wasn't it? And then you've clearly got that buy-in and that engagement all the way through. And even when you've managed to achieve what you set out to achieve, you're now still striving to look for where you can improve even more. And you've still got the team there with you. They're still engaged. It's really fantastic. Shall we open the floor up to some questions? Would anybody like to ask Mr. Moores any questions whilst he's here? Layla.
So thank you for that brilliant presentation. I want to ask if you'd received any resistance, because obviously you introduced a lot of change.
I suppose resistance to an orthopaedic surgeon just involves me getting a bigger hammer out. So all I needed to do was wave that a bit more. No, in all honesty, because we were on the national outlier registry, it was taken incredibly seriously by all the execs and all of the senior management, and they were nothing but supportive in all of our endeavours, because they could see that we actually did need to make realistic change. So we were very lucky that we were supported by all of that. But the reality is the momentum of our team and our communication was key. to all of this. So yeah, if it wasn't for particularly Louise Pickering, she's our ACP. She drove the vast majority of this and kept us all accountable, as all good senior sisters do. She kept me in check and made sure that we actually did all the things that we intended to do. So like I say, it takes one or two great individuals just to take the team and keep us all accountable and keep us all working hard to get to the end goal.
Thank you. That was great to hear. And I particularly wanted to comment on how much I loved the fact that you invited a neighbouring trust to come and join you and re-incentivise your team and get the energy back into the project. So well done. Thank you.
It really makes you enthusiastic, doesn't it? It really, really does. Have we got any more questions from anyone? Anybody else want to ask a burning question? Has anybody popped anything? Oh, yeah, here we go. Carl.
Yeah, so thank you, Mr. Moores. That was brilliant, and again, thank you to the organisers for being able to share the winners of these competitions. It makes it so much more real to hear from winners, and it inspires us all to go away and do similar. So that's a great change for this year. In terms of your project, I didn't hear, but was getting it right first time involved at all?
There's always elements of that because we're governed by those laws as well. So yeah, that all carries part of it. But in reality, the vast majority of the hip fracture work, it comes under the National Hip Fracture Database stuff. So GIRF links into that. But also we've got this best practice tariff, and we know that if we hit those targets, we're going to obviously get a financial reward. So they're what we're always aiming towards. But the reality is, for me, best practice tariff equals the minimum standard of care those patients should be getting, not the best standard of care. That's what all patients should expect to receive. So, you know, we should realistically be, you know, hitting 100%. For me, I get that's not realistic, but my point is that's what we should be aiming for. And I think sadly with all these sorts of parameters, patients could still get the best standards of care, but it's never recorded properly because of staffing levels, for argument's sake. Like, we didn't have a 7-day physio service that could handle our patients as such. We had lots of amazing physios that would come and do additional work on weekends, but it was so hit and miss, and that helped us put those business cases together to get these new members of staff and actually support that service. So, you know, it's all these different things that we've been doing that have made such a big difference and given us the armour to go to the management and say, this is what we need and this is the reason why. So yeah, so yeah, it does link in. Sorry.
Yeah, no, excellent, and you're right. It's all about teamwork, and it's just not just about medics doing audits. It's about multidisciplinary audit, including management. Because as I say, if we all work together as a team, then we can achieve, you know, the results that you've got. And again, I continue. I urge you to push forward and not just be happy with being in a non-outlier, but actually be an outlier for a positive outliers. Because you can, once you start the improvement, you can continue it.
Absolutely. I think that sounds like that's what you're planning, Mr. Moores, doesn't it?
Yeah, 100%. And that maintenance is actually the harder part. You know, you can make good early changes, but it's making it embedded into the fabric of what you do that actually it becomes the norm. So you can keep on making more improvements rather than fighting to chase what you've once achieved. So, you know, that's the most important thing. That's why breaking projects down into smaller chunks that are manageable and sustainable, that's actually more key to anything, rather than just trying to do one big thing and think, yeah, I've got a quick win. It's not about quick wins, it's about the long-term picture here.
Absolutely, totally agree. Hamida, you've got your hand up.
Yeah, I'm just going to take my hand down. Hi, Mr. Moores. I really enjoyed that. I work at a mental health trust. I've previously in and out of different jobs, but the first clinical audit post was in acute, and it was working with, as well as other things, orthopaedic surgeons, etc. So it is a bit close to my heart as well, and I think it's quite amazing, particularly from outlier status. But I'm just wondering, because there was scrutiny, because it's such a high risk area, and generally people with hip fractures have multimorbidities, or maybe older, or maybe need stabilising before they have an operation, etc., etc. And acknowledged that it was an outlier status, so it gave it that level of scrutiny. Is there anything that to be learned from that specific process that you went through to be able to translate or use in other areas that might not have that level of scrutiny, so may not have, wasn't an outlier status or might not be seen as risky? Is there anything to learn from that to be able to influence it wider?
Very good question. I think the reality is you can always learn from everything, and I think for me it's about scrutinizing your processes to make them as efficient as possible. So, you know, the clock starts when our patients with neck FEMA come in with a, you know, their injury, and we've got essentially 36 hours to get them to theatre. So the team has got to be so organised in order to start their care, optimise that patient to make them fit enough for a surgery. And, you know, we're operating regularly on patients over the age of 90. These are the highest risk patients. So you need, I suppose, the most risk taking anaesthetists who will happily take it all on board, you know, anaesthetising a very elderly, frail, multi-morbid patient, as well as having good surgeons that can deliver, you know, quick, efficient surgery. So it is just a team approach, and I think you just have to look at whatever you're dealing with, understand exactly what it is. You know, and hip fractures, they are the high risk, but we know that if you operate on them as early as possible, they do better.
Yeah.
So knowing that one fact from all the data in the literature, knowing that one fact, it means that you have to take that risk and that gamble to a certain degree. So if you leave them, they're more likely to, you know, to die. Their mortality risk increases by about 30% every day. So every further 24 hours after 36 that you leave them. So, you know, you just have to take that risk really, and you have to have a team that's also on board with treating these high risk patients.
Do you feel that because it was an outlier that gave it actually a bit more impetus? Because I'm interested in having that same drive, but I'm wondering if it would have the same impetus without it being an outlier. I mean, obviously, you know, you're passionate.
I think it definitely helped. It definitely helped having a need to change, because when, you know, your board is getting you know, told, we need you to report on hip fractures, why is this like this, how does this you know, how can we change it? You know, there was a drive coming all the way from the top of the organisation because they were very aware of it. But equally, every project, you know, and I think that the last few talks sort of discussed it, it's about finding the right projects and identifying those and making sure that you actually put all of your resource and effort into getting those projects done, no matter what area of medicine or healthcare it's in. It's about identifying those, because there's no point having 10 people wasting a load of energy doing something that's going to have minimal change. You may as well get those 10 people to collaborate and work really hard on a really crucial area of whatever area you're in. So you need someone overseeing your audit department and your governance department to say, actually, the priorities are this. And that's what we did. So we sat down and we worked out a list of priorities, and then we worked through, how can we improve this? One small project, one person, let's do this. Like how, you know, and that's the way we did it.
Yeah, that's brilliant. Thank you very much. The slide's going to be available, because I'd like, if possible, if you're willing to share them.
I'm more than welcome for you to have my slides. They're just very colourful, really, but you're more than welcome.
Thank you. That's wonderful. Thank you so much.
Thank you. Excellent. So we'll move to Sarah.
It's just a quick one. The chat is obviously, there's a lot of chat going on, but I just wanted to highlight to Mr. Moores and to yourself and Layla that at 13:34, Tom Johnson from Walsall Healthcare is saying, a question from Mr. Moores and myself and Joyce at Walsall, we're live streaming you into the QI training now. I hope they're still here. Do you think that the QI tools and techniques helped you achieve your project aims? I hope you don't mind me butting in with that question for them.
No. What I can say is Joyce and Tom are a phenomenal asset to Walsall, as well as QI across the country, because from what I understand, they're training pretty much everyone these days. Their course that they run is incredibly useful. It's fun, and all I can say is everyone should who is interested in quality improvement should do this course, because actually they teach you how to understand that you've made meaningful change, how to do all of these run plots and driver diagrams and all these different techniques. But actually that's what you need to understand, because, you know, doing an audit or any project without these sorts of measurable outcomes, you'll never know if you're actually making any real change. And I'm blessed because these guys, when we ask them, they come in and they oversee our project designs to make sure that what we're actually looking at is measurable. And then if it is measurable, are we measuring the right thing? So actually we do the project and run it once and we get all the right answers to see if the new interventions we're doing are actually making change. So I can only thank our quality improvement team in Tom and Joyce for all that they've done for us at Walsall.
That's fantastic to hear. Are they your audit team as well? Are they one team where you are?
I don't believe they are, because we have other people that run our audits. These guys are purely quality improvement, and they literally run lots of courses for lots of different people, certainly locally, and I'm sure they're even doing it nationally now. And COVID hasn't even stopped them; they still even are doing these virtual. So yeah, I can only recommend joining their courses highly enough. I've done it, as has the majority of my team. So yeah, they're fantastic.
Excellent. So I'm just thinking that yours is a fantastic example of a project where your clinical audit team and your QI team are set up differently, but actually you've all worked collaboratively to make sure that you're reviewing and plotting and presenting that data in the right way. So that's fantastic to hear. It's a really success story. So it's brilliant. Thank you so much for joining us and presenting, and congratulations again for winning. Fantastic. And we'll be in touch with some goodies and to get this written up as a case study on HCLIP's website and shared more widely. Thank you so much. So
my pleasure. Thank you, everyone.
It was brilliant. Enjoyed listening. So I'm just, I think, showing you another slide now on our network opportunity. Layla, I'm going to hand over to you if that's okay. We're on about 1:45.
Yes, thank you, everyone. So we wanted to ask you about your thoughts, and Rebecca is going to put in a Menti link into the chat, and we're going to ask you how you actually collect and present your data over time. So if we could ask you to click on there and actually feed back your thoughts, having heard two brilliant presentations. So if you could start to put it up and the slides up, so we'll start to see them as you enter your comments.
And this is really, really good to see, because I think making data count's been around for a number of years now, hasn't it? So it's just interesting to see how people have managed to apply it to their local clinical audits on their programmes.
So we've got someone being very honest and saying bar charts, sadly. So we would really encourage you to make the change. And rag rating. You don't say what rag rating you use, but as Sam has says, orange for concern and blue for good practice. So that's what we would recommend. We don't. Someone else said they don't collect and present data over time. Okay. SPC, fantastic. Run charts and SPC, so some really good practice out there. You do it with your KPIs, that's interesting. So there are KPIs and dashboards that people use to present data. They're not, KPIs can be SPC, it depends how they're done in different trusts. We've got, not yet, but hopefully as a trust you're moving forward towards the method, so that's great. And as Sam has said, there's a lot of training online and a lot of training via our website at NQ CAAW that you can access some great training videos. So I would recommend Sam's in particular. Tables and graphs, someone's written, so I hope they're SPC tables and graphs. Visually from SurveyMonkey, that's also really nice to do, and depending on your patient group, really important to use a variety of tools. Presentations from staff at meetings, teaching, that's really very useful. And the slide that captured me was actually sitting around a table presenting and talking about audit findings, which we don't do much here at our trust. We do it over MS Teams, but actually I'd welcome going back to that, sitting and talking about audit results. Run charts, midway, carry out a midpoint. I don't know what that says, to check the data as you're collecting it, okay? A small amount of SPC from someone, but still reg rating. So we can't encourage you enough to move away from reg rating into SPC charts and collecting enough data points to make it meaningful, and then implementing a change and then seeing if that change has had an impact. That's a lot there. Vicky, do you see any that stand out to you?
I just think it's absolutely fantastic, isn't it? And I think
Yes.
all of Sam's, it's really good because people are being open and honest here in terms of the fact that actually some people are really cracking on, having a go. Some people are about midway, some people not yet. I suppose it's just signposting you, because all of Sam's training videos are available. If you're not yet on the NHS Futures platform, go and get registered. There's the Making Data Count workspace there. All the videos are there. So if you haven't got time to register on the training programs themselves live, you can then listen to all the training programs when you do have time. And then it's just taking it back to your organisations and your teams and just thinking, how can we apply it? And I know, as Sam said, she works with boards, so she does come out into organisations and present at board level and start to get them to think about how they can plot their data differently and review it differently, and bringing in that real triangulation. So again, if she's not been out to your board, maybe speak to somebody in your organisation and see if you can invite her and a team in. So yes, it's really, really good stuff. It's good that we can talk quite openly and honestly with each other as well, because the whole point is that we do learn from each other. And I think Mr. Moore's his project was a good example of that, where they obviously went off to Rotherham and they learned from how other organisations were doing it well. So this is really good, and it's just flowing, isn't it? Absolutely. I don't know if you've got any more questions that you wanted to ask, Layla.
So I think, can we move on to the second question, which is, what roles within your trust review the data and actually make the decisions about taking action? So thinking about who makes that ultimate decision, who do you have involved in that process? When you review the data, is it done in isolation? Is it done in collaboration? And as Vicky's mentioned, new ways of data triangulation, do you do that? So let's see your comments as they come through and see what you do. So there's sort of two questions in one. So that's my fault. As an auditor, I know better than that. So I have to say, I should have chopped them up. But who reviews the data?
Stopping and making yours think now, aren't they?
Yes.
Might be different depending on which projects you've got on your programs as well.
Definitely.
Different priority drives different ownership, doesn't it?
So someone has actually said, depending on the data, absolutely, mainly clinical governance, which I have to say in our trust, we do exactly the same. We tend to make the decision on very large trust-wide audits. The steering group, who are a subcommittee of the board, absolutely. So you might then present the data and the steering group may have comments on the data and want certain things highlighted. Project stakeholders is fantastic to read and see. Thank you. That's really good to know that you go back to your stakeholders and they make the decisions around data and the decisions to be made. Clinical leads, absolutely really good to see. The full project team, so clinical audit team, I'm assuming, clinicians and others. Really good decisions at various levels, depending on the project. So that's really good. Auditors, audit supervisor, yes. So in our trust as well, for little local audits, it's definitely with the audit lead, but it could be for a larger project as well. And clinical governance group. So I'm assuming that's a slightly wider group than a clinical governance department. So really good comments. Using data from EPR now for improvement work. That's really interesting to see. So that's the electronic personal record from staff. it went. I couldn't see the rest of that, but that's a very useful tool to use. Now for improvement work. Thank you, Becca.
Yeah. Is that the electronic patient record?
It might be the yes,
Yeah.
it in different places, of course.
Which is fantastic. It's serving its dual purpose, isn't it? Making sure we've got data there that we can pull out when we need to and plot it over time. It's fantastic. It's embedded in the system already, isn't it?
So some people are very focused on the audit lead and supervisor and perhaps the clinical effectiveness team, and others are very collaborative in involving their stakeholders and wider partnerships. So we would encourage you to involve your stakeholders and wider partnerships so that in your analysis of the data, you bring that knowledge so that they're actually looking at the data with you. Often it's seen that clinical audit teams are neutral and therefore the best place to analyse the data, but actually the collaborative approach is much more powerful to the results that you receive. So thank you for that. Vicky, Sarah, do you see any others that you want to highlight?
I think it's really good. It's really good, isn't it? We're getting results far and wide and up to the right people. And maybe if you're not yet getting those results to the right people in the organisation or maybe higher up the tree, it's about thinking about how do you have that process for reviewing and acting on results in your own organisation. So it's really good. And again, we're going to share the outputs of everything that people are putting here, totally anonymous. So it doesn't come back to you as individuals posting it, but it's really good to read so we can see what's happening in other areas and we can take top tips and take them back to our own organisations. It's really good.
Thank you. And I think, sorry, we have one final question, don't we? And that, if we have time, and that final question is, what would you like to see NQ CAAW22 doing to support effective change through clinical audit? So what would you like to see us producing and doing for you?
Lovely. So that link's gone in. So we'll move you across there
in
the minutes, and then we'll be looking to just sum up and promptly get you off to whatever next on your agenda for the afternoon. So it's been a really, really good, valuable session. I'm so pleased that you've all joined us today. And we'll obviously we're hoping that we've infused you to take things away back to your own organisation. But yeah, what is it that we could potentially do for you from today?
So I like the comment we received about helping the sharing of learning across trusts, and I was particularly struck by the presentation that they invited a neighbouring trust to come and talk about fracture neck femur, to not only infuse staff, but actually to share that learning across trusts. And that's the whole purpose of our forum. So there is a minefield of information on that forum that you can find, learning projects, fantastic tools, comments, people asking questions, people responding. So the sharing of information is definitely there via our forum, and I would really encourage everyone to go on and look and see, because the questions you're toying with within your own departments will have been asked and answered on that forum, I can guarantee you. And if not, we are here to then answer you and help support you through that. So we can help you, but I would suggest via the forum. More sessions like this across the regions, absolutely. So if you're not a member of a network, please do so, because in the networks we try and do sessions like this. This has been particularly good to hear real audits that have made such huge change to practice. Real world examples of action plans, examples of good clinical audits. So you will see a host of good clinical audits again on the forum. And can we provide training sessions? So yes, we do. And I would suggest again that your main link is through NQ CAAW22, because all of that information is there. It's easy to say, but actually, please, can I encourage you to go on, because you will find answers there and access. And of course, you've got your regional chairs. So right at the beginning, Vicky talked about the regions. So it's all there. Vicky, I'm going to hand back to you, because I don't think we've got any more comments coming in. And
lovely, that's brilliant.
Thank you.
Just really quickly, because I know you consciously you're all probably planning to leave at 2 o'clock. So it's just to highlight to you, thank you again for joining today. Becca's going to put a link into the chat for an evaluation form from today's session. Please, please, please do click on it and fill it in and be open and honest with us in terms of how you found the session, because we will use that feedback to look at future events for you all. So it's, please do just spend 2 minutes, a really easy form to fill in. And it's just to highlight to you that tomorrow we're talking about health inequalities. Sarah, our General Secretary, is chairing. We've got Sarah Byrne from our Mersey Quality Improvement and Clinical Audit Network, who will be facilitating, and Caroline Rogers, one of the directors at HQIP, talking to us about health inequalities, massively high on our agenda at the moment in terms of improvements. And then on Friday, Future Proofing Healthcare, James Mountford, the National Director for Improvement Strategy, will join us and is going to wow us with all the things that are going on in NHS England and improvement to make sure we're future proofing health and care as we move forward. And Mojgan, who's our South East Clinical Effectiveness Network Chair, will be joining us to facilitate that session. So please do, if you can, join us, and all the sessions will be recorded and available on the NQICAN YouTube channel, but also on HQIP's website as well. So if you're on Twitter, get tweeting about Clinical Audit Awareness Week, tag us in at NQICAN and at HQIP, and thank you so much for joining us. We hope you found it valuable. And don't forget about those few challenges that we set you earlier in terms of taking back to your own organisations. And we look forward to seeing you here Thursday and Friday, and then on the forum and in your regional networks. Take care and have a good afternoon. Thank you.